Good afternoon, everyone. Thank you so much for joining us here today for Year in Review. And we have the pleasure of having four amazing speakers and speaking really to a breadth of topics ranging from mental health, vaccines, clinical trials, and artificial intelligence and imaging. So without further ado, I would like to first introduce ourselves. So my name is Ranjini Somayaji. I'm an adult infectious disease physician in Calgary. And this is Dr. Pierre-Régis Bourgel from?
From Paris in France. Thank you, Ranjini. So with that, we're going to start with the first speaker, who is Professor Guillaume Chassagnon. Guillaume is a radiologist. He's a specialist of CT imaging and artificial intelligence, and he will review the year on this topic. Guillaume, the set is yours.
Thank you very much. Thank you for the invitation. So, as Pierre just told you, I'm a radiologist and we work in the same hospital. So I will talk in this lecture about artificial intelligence and imaging for cystic fibrosis. I have no disclosure. So first, when we want to speak about AI, we have to understand a little bit how AI works, and it's very important to consider that AI is not magic, it's just mathematics. So we'll just see within a few slides how it works in practice. So for image analysis, we have two different approaches that we can use. The first one is called radiomics, and it's based on classical machine learning methods. It's also what we call textual analysis. So radiomics is this. In fact, it requires a preliminary step of feature extraction, which is very important. Because, in fact, if you want to use radiomics, you have to know that radiomics or machine learning algorithms are blind. So if you want to use this image and to classify whether it is or not a cancer, for example, you will first have to describe the image to the machine learning algorithm to ask him to decide whether it is or not a lung cancer. And to describe the image, we will have to extract what we call a radiomics feature, which are a combination of features about attenuation of the lesion, histogram analysis, shape and texture analysis of the lesion. And then we provide this radiomics feature to the algorithm, and we ask the algorithm to create a model to decide whether or not it is yes or no. The second possible approach is deep learning. So deep learning is very popular because usually it performs better than radiomics and classical machine learning methods. It's what we call an end-to-end approach, meaning that here you can provide the whole image to the network, and the network will provide the prediction. The only drawback of deep learning is that it requires more data than radiomics. So how does it work for image analysis? For image analysis, in fact, we use convolutional neural networks. So these convolutional neural networks are made of convolution, and convolution is just a mathematical operation where a convolutional kernel is applied to a matrix, which is the image, to create a new image, which is the output. And for example, here you have an example of a convolution which is applied to this image. It's a very simple convolution, and you see that you get a new image at the end. And when you use a CNN, in fact, you will do a lot of successive convolution to the image, so you will transform this image into a new image, which is what you expect to have. For example, here, it's an example of a model doing interstitial lung disease segmentation. And if you don't want a segmentation, if instead you want to have a classification of the image, you just have to change the second part of the network to replace it by a fully connected layer, which will combine all the information from the initial convolutions to create a prediction of yes or no. So this is how AI works, or briefly how AI works for image analysis. So now let's see some application in cystic fibrosis. First of all, we can use AI to do classification tasks. For example, here, a classification task is from a chest X-ray to get a score. So these studies, which has been published in 2024, they use 2,000 CT scans to train, validate, and test their model. What they did is that they asked radiologists to score the images using the Bradfield scoring system. So one radiologist did the ground truth to train the model, and 4 additional radiologists annotated the test data set to evaluate the performance of the model. And as it is a chest X-ray, it's only a 2D images, so they used a 2D CNN. And this is what they obtain. They obtain a network which is able to provide a score corresponding to the image, so a Bradfield score, which is automated here. And you can see on this image, these are the attention map you can get from some type of deep learning architecture. So it shows where are the areas the network focused on to provide the score. And we can see here the score we add from the network and the correlation we had between the model and each radiologist. And you can see that the correlation are quite good. And if we do a comparison between these performances and the preferences of the radiologist, we can see that the AI performed as least as well as radiologist in 3 to 5 out of 5 cases for total score, and for up to 5 cases for depending on the type of lesions we were looking at. So AI can provide automated scoring of chest X-ray. This is another example of studies using AI for classification tasks. It's a study we did 2 years ago in the department with the pulmonology department. So what we did, we included 201 chest CT from patients treated by lumacaftor, ivacaftor. There were a baseline CT scan, so a CT scan prior to the initiation of the treatment. We used a radiomic approach, meaning that we extracted a radiomic feature from the images, and then we did some clustering just based on this radiomic feature to create several clusters of patients. So at the end, we obtained 3 clusters of patients, and what we saw is that among these 3 clusters, one, the cluster C, was composed of younger patients with better pre-therapeutic FEV1, fewer CT lesions, and they had a better response to treatment. So AI can perform classification based on images. We can also use AI to do quantification, and we are going to see some example of AI tool for quantification on chest CT. When you think quantification, chest CT, and cystic fibrosis, the first thing you want to quantify are the bronchiectasis. So this is a first paper published in 2022, which has been published and which show how to quantify bronchiectasis on CT images. So it had been trained on data from 39 CT scans, so it's a few, but on the CT scan, they extracted 19,000 patches, and these patches were annotated. So patches are small images which were annotated by chest radiologists, and then they trained a 2D model to be able to classify each patch to detect, to say that if there is or not bronchiectasis and the type of bronchiectasis which is present on the image. So they used a 2D deep learning approach, and these are the results they obtained. You can see that the lungs are divided in patches, and for each patch, the network is able to say either yes or no bronchiectasis, and in case of bronchiectasis, it says the type of bronchiectasis. It is a cylindrical, a varicose, or a cystic bronchiectasis. Another way to use AI for bronchiectasis quantification is this. So this is a commercially available tool which is able to measure the size of the bronchi and also to measure the size of the corresponding arteries. And in these studies, the authors, they use data from 481 patients from 3 data sets to assess the performance of this tool. So as image analysis, what they did, in fact, they had bronchial and artery measurement for 30 CTs in one of the 3 data sets, and from the 2 other data sets, they had the Pragma CF score, which is a visual score that had been performed before. And also they had access to lung clearance index. And these are the results they obtained. So what they observed is that there was an excellent agreement between the automatic and manual bronchial and artery measurement. This was excellent for the ratio between the outer diameter of the bronchus to the artery, and there was a systematic overestimation of the ratio between the inner diameter of the bronchus and the artery, and an underestimation of the ratio between the bronchial wall thickening and the artery. So this is a tool which is able to assess the size or the diameter of the bronchus and of the artery in an automated way. So it's able to measure a lot of bronchi and a lot of arteries on the CT scan, which is not possible for a human. And what they did, they also assessed this tool in the two other cohorts they had to see that there was a strong correlation with the Pragma CF score. Using the Pragma CF score, in fact, they were able to detect a progression of the disease only in one of the two cohorts they had, whether when they used this AI tools, in fact, they were able to depict the progression of the disease in the two cohorts, meaning that this AI tool is more sensitive to changes in imaging. So these tools have also been used in another data set here to assess the efficacy of inhaled hypertonic saline in children. So they had 115 patients, 230 scans because they had baseline and follow-up CT scan. So they did all the measurements using the software, as they also had lung clearance index. And what they did, so with the automated software, you can measure a lot of bronchi and a lot of arteries. So they had 12,000 pairs of bronchus and artery measured at baseline and 14,000 pairs of bronchi and arteries measured at 40 weeks. And what they observed is that you can see that there were differences between patients treated with isotonic saline and patients treated with hypertonic saline. So AI can be used for this. Okay, but cystic fibrosis is not only made of, or you not only have bronchiectasis, you also observe other types of lesion, and this is a very interesting works from a French team from Bordeaux. And what they did here is that they trained a tool to segment, so meaning to contour all the lesions on all the CT scans, or not all the lesions, but some of the lesions. The lesions trained the algorithm to contour were bronchiectasis, bronchial wall thickening, mucus plugging, bronchial mucus, and consolidation, so 5 different types of abnormalities. They used a 2D network, so it performs the quantification slice by slice. And what they observed in this 2D, so they trained it on 114 patients, and then they applied it on 70 patients with 2 CT scans for each. And what they saw is that in patients with treated by lumacaftor, ivacaftor, there was a significant decrease in peribronchial thickening, bronchial mucus plug, bronchiolar mucus plug, collapse and consolidation, and the total abnormal score. So this automated scoring method was able to depict significant changes under treatment. Okay, but lesions also include small airway disease, not only large airway disease. So this is another tool which was trained to assess air trapping in patients. So it also used deep learning data from 36 patients with cystic fibrosis. They also performed a quantification of the lesion, used a fixed threshold of minus 856, a personal threshold of that was decided by radiologists for each patient, and a manual selection of the best threshold. And they also used a 2D CNN, and what they obtained was also that they were able to quantify air trapping on chest CT, and their quantification was more sensitive to the changes over time. And at last, this is a paper that we submitted, and so this is a tool we train here to quantify lesion from large and small airway disease on inspiratory CT scans. So we trained the tool on 250 CTs, and then we applied it on a cohort of 436 CTs from patients treated by ETI, and so we trained the network to segment 7 types of lesions, so bronchiectasis, bronchial wall thickening, mucus plugging, centrilobular nodule consolidation, but also emphysema and mosaic perfusion. And these are the kind of results we obtained. So we were able to have a very accurate segmentation of all the lesions on the CT scan. So for this, we use a 3D approach, not a 2D approach. And when we compare the accuracy of the segmentation to the accuracy of the segmentation of radiologists, what we found is that the accuracy of the deep learning tool was at least as good as the accuracy of each radiologist, meaning that the difference between each radiologist and the automated tool was the same or smaller than the difference between the two radiologists. So it means that the tool is able to provide like a mean of what a radiologist, of what several radiologists would have said on this CT scan. And you see here that the tool is able to perform the segmentation of bronchial wall thickening, the bronchiectasis in red, but also of mosaic perfusion. So then we applied it in our cohort of patients treated by ATI, and we saw that there was a significant decrease of all lesions except bronchiectasis and emphysema. Why there was no decrease of bronchiectasis under treatment? Because on baseline CT scan, in fact, the bronchiectasis were full of mucus plugging, so they were considered as mucus plugging and not as bronchiectasis. And when the mucus plugging removed from the bronchi, in fact, the bronchi were then considered on the follow-up CT scan as bronchiectasis. So it's why we have this increase of bronchiectasis, but which is artificial. We also use this tool to assess the relationship between functional and morphological changes. And what we saw is that the parameters that were independently associated with FEV1 impairment prior to ETI were the extent of mucus plugging, consolidation and atelectasis, but also mosaic perfusion, so a mix of large and small airway disease. And what we found also is that the independent predictor of FEV1 increase under ETI were the age of at ETI initiation, but also the extent of mucus plugging on the chest CT prior to the ETI initiation and the extent of the centrilobular nodules on chest CT prior to the ETI examination, meaning all the lesions that fills the bronchi. We can also use AI for to quantify things that are not the lung. And for example, here it's a tool that has been developed to quantify muscles and fat in patients treated by ATI. And so the authors saw that there was an improvement of fat and muscle under treatment. We can also use AI to perform segmentation on MRI images. And for example, lung segmentation is very important when you want to do a quantitative functional MRI. So this is an example of tool that has been developed for MRI. And here it is another fancy study that has been performed also in Bordeaux. And what they did in this study is they use AI to generate synthetic CT scans, so artificial CT scan, directly from MRI, so to enhance the quality of MRI. And so in A, you have an MRI, so it's a UTE sequence. Then on B, it's a synthetic CT scan. So this CT scan has been made from the MRI. And on C, it is the actual CT scan of this patient. And you can see that it is able to enhance the quality of the image. So this was done on a cohort of 110 patients. They use a GAN network, and they assessed the performances of the new images they were able to obtain. And this shows that there was no significant difference between in signal-to-noise ratio between all imaging modalities. That UTE MRI was at a lower quality score compared to the two others, so the CT scan and the synthetic CT scan. There was a better agreement between real CT and synthetic CT scan, and for junior radiologists, in fact, it was easier and they were more accurate when they scored the synthetic CT scan rather than the MRI. Okay, so AI is very good, but it has some limits, and we have to be aware of it. So first, limits for classification. You have to know that deep learning it's a black box, and it does not think like human. This is an example to show you that it does nothing like a human. This is a network that has been trained to annotate images from the internet. And you can see here that the revolver is correctly annotated as a revolver, the vulture is correctly annotated as a vulture. And then you just apply a small flip to the images, and the gun become a mousetrap, so it's still lethal. But a vulture become an orangutan, and you can ask my 2-year-old boy, and he will not make this error. So it's able to do like huge errors. This is another example to show you that image quality can have a huge influence on the classification from this network. So it's a very questionable data set where so-called experts were asked to rate the beauty of women's faces. And you can see on this study, so they did it. And then what the author did, they added some noise to the image, so it's a white noise. You almost not see any difference between those two images, but if you do the subtraction between these two images, you get this, okay? So the images are a little bit different, but you can not even see the difference. And just by adding this noise, in fact, the beauty of the ranking of the beauty of the woman become very different. So small difference can have a huge impact. Another limitation is that we need to be able to verify the results, and in most cases it's not possible. And also, we don't know how this tool will behave with future evolution. We know that now we have phantom counting, and we don't know how these tools will behave with phantom countings. AI has also limitation when it comes to quantifications. We don't know if the measurements are robust enough to be used in clinical decision making. We don't know the precision and the variability of the measurements. There might be some, and obviously there will be some difference between tools. Also, we know that there will be differences if you perform 2 times the acquisition, because due to the level of inspiration, you will not get the same image, so you will not get the same quantification. Also, if you use a different positioning of the patient, you will have different images, and this will influence also the segmentation of the lesion, so the quantification of the lesion. So to conclude my talk, we saw that AI offers a lot of new perspectives for the development of a new imaging biomarker, also to automate existing visual score. This could help to a better understanding of the disease. Can we use it in clinical practice? I don't know yet, because we have to prove that it is robust enough. And also, I'm a radiologist, so I should told you that AI cannot replace radiologists because it has many limitations, and you have to be aware of this. Thank you very much.
Thank you for the really interesting talk. And so just so everyone's aware, you can either come up to the mic and please introduce yourself if you're coming up to the mic for a question, and then, or you can use the app as well. And even if one of you want to send me a test just to know if the app is working, because I know it's been variable in some sessions.
So maybe I'll start with the first question. Guillaume, you showed us many data from research project on artificial intelligence on CT scan, but AI is everywhere in our life at the moment. When we go on Google, when we go everywhere, we have AI algorithm. So how far is this from daily clinical use? Can this algorithm be directly implemented in commercially available CT scans?
So it's very important to consider that there is a huge gap between research and clinical practice. And so now we are more in clinical practice. In fact, we use AI in our daily routine, but not for cystic fibrosis. We only use AI for image analysis, because we use AI for the reporting, for example, for the mic. But for image analysis, currently we only use AI for chest X-ray analysis and for lung nodule detection, and we'll also have some tools to detect like pulmonary embolism, but I don't use these kind of tools. But here, like for tools for quantification, I think we are quite far away from clinical routine, because, I mean, to date, there is no data about the reproducibility of this measurement. So we don't know if we have, if 2% of the lung are occupied by bronchiectasis, we don't know if we repeat the CT scan the same day, what will be the measurements, the second measurement. So we cannot use it yet.
So we have another question here in the app. Is AI faster or does it require less radiation? Like, could you get away with less radiation or a shorter imaging study as well?
What do you mean? Is the question, can we have can we decrease the dose using AI?
Right.
Okay, yes, but not with the tool I shown you. So when we do CT acquisition, we have what we call the sinogram. So it's the raw data from the machine, and then we have to reconstruct this data to make the image you see on the PAC system. And for this, now we use deep learning, and these deep learning tools are able to have data with lower dose to create the CT images. So we are able to decrease the radiation dose from CT scan using this kind of algorithm, but it is not the algorithm I shown you just before. The algorithm to do quantification, we need sufficient dose. It's more likely that if we decrease too much the dose, we will have poorer results for quantification.
Thank you.
Several people online or in the audience use the app to ask more or less the same question. You showed us how critical it is, how you train, which sample you train your AI algorithm. So in CF, we have pediatric patients and adult patients, and how often pediatric CT scans were used in this to train this algorithm? Is there any reason to think that there's a difference between pediatric CT scan and adult CT scan?
Yes, obviously there are some differences because I'm doing only adult imaging, so we don't have a pediatric population at my hospital. So in adults, we only perform inspiratory CT scan. So there are adults that are able to have a deep breath and to hold it. In most of cases. In children, it's not the case. So a lot of CT scans are performed as in free breathing status. So it means that the images is not the same. The densities, the attenuation of the lung will not be the same, and there will be some differences between image obtained in adults and image obtained in a pediatric population. So tools, if you want to use it in a pediatric population, it has to be developed using pediatric data. And it's the case for several tools, but not all.
Any other questions? Okay, thank you so much.
Thank you.
So next we'd like to invite Dr. Sophie Corriveau to come up. And she'll be speaking to us about mental health in the modulator era. Sophie is an assistant professor and a respirologist and also the director of the Adult Cystic Fibrosis Clinic at McMaster University.
Thank you for the introduction and thank you for inviting me to speak today. So as she said, today I'll be speaking about mental health consideration in the post-ETI era. These are my financial disclosures. So the purpose of today first is to really look at what is the prevalence of depression and anxiety among our patients with cystic fibrosis. Then we'll review longitudinal mental health trends in CF, and lastly, try to answer the question, how ETI affects mental health. So some things are clearly well established with regards to ETI and CF. We know there's improvement in lung function, improvement in BMI, reduction in sweat chloride, improved respiratory symptoms, and decrease in pulmonary exacerbations. However, there are some side effects that have been reported in various case studies as well as some of the clinical trials, and these we don't know as well. So things like cognitive fogging, difficulties with memory and concentration, increase in anxiety and depression, insomnia, suicidal ideation, and negative body image. I found these two contrasting quotes on the CFF website, which I felt was interesting and really kind of paints the picture of probably some of the patients we're seeing in our clinic. So in one sense, someone's experience with ETI has been, how can something that makes me feel great so physically great make me feel crappy mentally? And on the other hand, another patient saying, I have so much mental and physical energy that I just don't know what to do with it. So very contrasting experiences from our patients. So before we answer the question about the effects of ETI on mental health, we really need to understand the baseline prevalence of depression and anxiety in our patients. So as most of you are aware, this is results from the TIDE study that was published in 2014, international epidemiologic study that took place in 154 CF centers in 9 countries. It included over 6,000 patients over the age of 12 years old. And essentially what the authors found was that there was a significant higher rate of depression and anxiety among people with CF, anywhere from 2 to 3 times higher the rate than in the general population. Other studies have also identified a higher rate of suicidal ideation, with a report of 11% in adults with CF and 22% in adolescents. These findings led to the implementation of guidelines, and this was recommended by US as well as European CF societies. So essentially, it's recommended that all patients with CF have annual screening with PHQ-9 and GAD-7. So I'm going to discuss these questionnaires because they will come up throughout this presentation. So they're both self-administered questionnaires. The PHQ-9 is measuring depressive symptoms, and there's one question asking about suicidal ideation. The answers are then quantified in terms of categories, so 0 to 4, no symptoms, then mild, moderate, and severe. With the GAD-7, similar classifications, except this measurement is looking at anxiety. So what these authors did, which was interesting, is following implementation of this yearly screening, they were able to look at their own center and see what have been the longitudinal trends for depression and anxiety. So this is a single center in Cincinnati Children's Hospital. So essentially what they see, so on the left, we're looking at GAD screening, and on the right, PHQ-9. The darker gray is looking at minimal to no symptoms, and as you can see, from 2016 to 2021, this increases, whereas the proportion of patients experiencing mild symptoms decreases over that time. Patients in both the moderate and severe categories remain stable, and this is despite COVID pandemic in 2020. By 2021, in this study, they had about 95% of their patients who were on modulator therapy. The results of PHQ-9 screening were quite similar. Other things they looked at were other associations. So for example, not surprisingly, patients who had CF-related diabetes were more likely to associated to have higher scores, whereas those who had higher FEV1 had lower PHQ-9 and GAD-7 scores. And they also identified that more modulator use was associated with lower PHQ-9 scores. So certainly we've all heard of real-world case studies, and what do these tell us about ETI on mental health? The purpose of this is more to demonstrate that there's been lots of case studies in the literature where patients have had varying degrees of symptoms. So this is one example of a case series with 6 patients ranging between the ages of 14 to 45. And patients had symptoms such as fogginess, difficulty finding their words that were generally experienced within 1 to 2 months of starting ETI therapy. In 4 of the instances, they had change in their dose, or flipping, alternating morning and PM dose. And then eventually most of them had an improvement in their symptoms. 2 of them never went back on therapy. So why might this be? There's been 4 hypotheses to account for some of these effects. One may be that the symptoms are completely unrelated to ETI. Maybe this is due to existential impact on daily functioning, fertility, and lifespan. And certainly this is something we've seen in our own patients who are now, there's a different anxiety to wonder, how long is this going to work for me? Maybe some survivor's guilt or other concerns about some life decisions that they've made. Perhaps there's a direct effect of ETI on receptors of the brain. Certainly CFTR is expressed in the brain, however, its role is not as understood. And ETI is lipophilic, so can cross the blood-brain barrier. Lastly, potentially there's drug-drug interactions that could be at play. A few things to consider when we're hearing about these case reports or reading is certainly it doesn't account for the background epidemiology of depression and anxiety in the people with CF. Also doesn't account for the fluctuating nature of anxiety and depression. So people can have times of stability and times where their disease is worse. Also, premorbid mental health condition is not always as clearly outlined in these case reports. And certainly presence of external factors. So COVID pandemic, for instance, occurred at around the same time of availability of ETI therapy. So thankfully, we do have some data to look at longitudinal effects of ETI on mental health. So this is one study from the Bambino Children's Hospital in Rome. They included patients who were 12 years of age or older and eligible for ETI. They were recruited 2 weeks prior to starting ETI, and then they had multiple measurements, which they would do at baseline and then up to 6 months following. Some of these outcomes included PHQ-9, GAD-7, SDMT, which is the symbol digit modality test, and this is looking at processing speed, working memory. They asked patients about neurocognitive side effects, and they asked about CFQR. So in total, there were 92 patients with a mix of male and female. Most were adults with mild lung impairment who had never been on modulator therapy before. 17% of patients had a history of CF diabetes, and no patients were on antidepressant medications. So this is a bit busy, but the first row is looking at PHQ-9. So it starts out that baseline score was 3.7. And over time, you can see a statistically significant difference in the mean score of PHQ-9, which is 2.8. What is minimally clinically important? That we don't know as well. But nonetheless, this was stable over time, showing that there were improvements found in depression. Also, you see a higher proportion of patients reporting no symptoms. Now, GAD-7, which is the bottom column, the mean score was not very changed over that 6-month period. So there was no benefit, but no worsening in the symptoms of anxiety. Now, what's not shown here is when patients were asked about certain symptoms, about 30% of patients reported headaches and 20% reported memory problems. Interestingly, though, the results on the SDMT, which measures that cognitive processing, actually improved over time. So the key takeaways from this study was that there were significant improvements in both in depression reported over time. However, there was no significant change in anxiety. Participants reported neurocognitive side effects, which did not improve over time, and this was more common in females. However, one of the limitations was that baseline symptoms weren't assessed. So patients before starting ETI were not specifically asked whether they had these various symptoms. So this is a study with similar intent, and it was a Canadian study where GAD-7 and PHQ-9 scores were extracted from July 2021 and September 2023, and they included patients if they had baseline scoring and then 6-month post-ETI scores. So out of 117 patients who were initiated on ETI during that time, 85% of them had baseline scores, and then 77% had up to 12-month scores. Those who were missing data were more likely to be male, younger, and have mild disease. So what they were able to show was that there was a lower proportion of individuals with at least mild symptoms, and this remained stable in that 12-month period. There were 30% of individuals who had improvement in their PHQ-9 score at the 6-month post-ETI. However, 10% of patients did have worsening in their score. They did also look at suicidal ideation. There were 10% of patients who reported this at baseline, and this remains similar during the study. When we look at GAD-7 results, there were no significant changes across the anxiety symptom severity scores during the 6-month period. However, there was a reduction in the proportion of individuals with mild symptoms at the 12-month period. 20% of patients reported improvement in their anxiety score. However, there were 10% of patients who had worsening. So the key takeaways are that overall symptoms of anxiety and depression did eventually improve at that 12-month mark on ETI. Those with significant or worsening improvements were more likely to have pre-existing psychiatric diagnoses or require psychotropic medications at baseline. There were no meaningful change with regards to the proportion of patients who had severe symptoms. It's important to realize, though, there were 10% of patients who did have a worsening of their symptoms. So there has been a systematic review that was published to look at what we're trying to answer today. So this was published in the Blue Journal just this year, and essentially the authors were systematically reviewing and evaluating depression-related data in people with CF 6 years of age and older. They had multiple data sources, including clinical trials, post-marketing reports, interim registry-based post-authorization safety studies, and review of the published literature. So this is first looking at clinical trial data with the pivotal study shown on the left, 445102, and then pooled data from 14 other clinical trials. They looked at the exposure-adjusted rate of depression-related adverse events, and this was calculated on per 100 person years. So starting with the pivotal study, you see that there was an adjusted depression-related adverse event rate of 5 per 100 person year in the placebo group compared to 2 in the ETI group. And then again, the results are similar with the pooled data. In total, in the pooled data, there were about 12 patients who did have symptoms of suicidal attempt or ideation. In 11 of these patients, that ended up resolving with ongoing ETI, and in one of the patients, they were actually not on ETI at the time of those symptoms. So this is results of a global safety database. So this would be any reports that come through. A search of Vertex Pharmaceutical Global Safety Database had identified over 1,000 depression-related adverse events out of 61,000 patients treated with ETI. So this would be 1.3 per 100 patient year. As you can see, there are low numbers in general with regards to suicidal attempt and ideation. However, very little information was available because this is more just a report in general with limited individualized data. This is interim results from the registry post-authorization study. So in this case, this is centers looking at depression prevalence in their center, and they looked at 5 years pre-treatment with ETI and then each of the years after ETI. So this is looking at US registry cohort on the left and the German registry on the right. So there's a clear difference in point prevalence, but really the story is similar. So in the US, you see a general rate of increasing over time, and this was seen in the 5 years pre-ETI and remained stable afterwards. And then with the German data, it's fairly stable during that same period. And this is despite COVID pandemic as well. So lastly, the literature search looked at case reports, case series, cohort studies, and any studies using PHQ-9 before and after initiation of ETI. So this is looking at those studies that looked at PHQ-9 change. In total, there's over 900 patients, mainly done in adults, with one study looking at pediatric patients. The follow-up in PHQ-9 ranged anywhere from 3 to 12 months. And in general, every single one of those studies either showed no change in PHQ-9 or a decrease, which suggests an improvement in symptoms. So the key takeaways from this study was depression-related events were observed in people taking CF ETI were consistent with background rates of these events in the CF population. PHQ-9 scores either decreased or remains unchanged after initiation of ETI. We have very limited data in children, and this systematic review looked specifically at depression and did not assess anxiety or other neuropsychiatric symptoms. So where do we go from here? At a population level, based on what we know, ETI therapy does not appear to be associated with worsening symptoms of depression and anxiety. Having said that, there are a proportion of patients who do seem to have worsening in their symptoms, and it's really unclear whether this is because of fluctuating nature of depression and anxiety, whether it's due to ETI, or whether it's due to other confounding variables. Can we identify these patients early? Based on one of the studies I showed you, it seemed to occur more so in patients who had pre-existing psychiatric conditions to begin with. Is this a starting phenomenon that will improve over time? I've shown you some case reports of patients whose symptoms eventually improved despite limited change. And what are the effects in children? So very few studies looking specifically at this. I think the main thing to remember, of course, is depression and anxiety is very common in patients with cystic fibrosis. So it's important that we do screen them regularly, especially in the era of ETI. And I'd be happy to take any questions.
Thank you very much. Very nice talk. This is now open for questions.
And certainly if any of you are experiencing the post-lunch lull and you come up to the mic for a question, there are candies up here too that you can take.
Do I get a candy after finishing the talk?
Absolutely, absolutely.
Maybe I can start with the first one. Many times in your talk, there were data about questionnaires, and you mentioned the fact that they are screening questionnaires, and then they're used as diagnostic tools. So is this really anxiety and depression in the patients, or do we need to confirm diagnosis with psychologists, psychiatrists, I don't know, and how much does this affect the quality of the data?
Right, good point. I think at this point, having standardization, it helps to use these kind of scoring tools because at least from a various center, you can use the same thing. When it comes to diagnosis, given the fact that this would be based on DSM, which is typically administered by psychiatrists and so on, I think it would complicate things. So I think having at least scoring systems as opposed to just reporting is a step in the right direction. So some of the data I showed was just based on a report of depression or report of anxiety. So ideally, even though you're right, PHQ-9, GAD-7 are not diagnostic, but generally are showing the symptoms that that person's experiencing, which for that person, whether or not this correlates with a diagnosis, I think is least important as opposed to their symptoms that are bothersome to them.
I see Professor Barry Plant.
Hello, thank you, Barry Plant, Cork, Ireland. Thank you for an excellent talk. The thing I struggle with, though, it's more a comment, is we're getting ourselves into a position where we know ETI is brilliant. We know it works. It's really good. So then when you start talking about some of the things that might happen to people in it, everyone's like, you know, it does, you know, we focus, by saying something negative, people are worried that in somewhere we're saying that we shouldn't be using ETI. And I just think even when we do our conclusion shouldn't be that the majority of people do well from an anxiety point of view and depression. Of course they do, if your lung function goes up and you're not exacerbating, etc. We know that's a given. But we need to remember, as you highlighted, there are 10% of patients that this drug is a challenge for from a neurocognitive wellness point of view. And I think sometimes people are almost kind of frightened about saying it and it's like, did you do a GAD score or not? As opposed to look at social media, look at what the patients are saying, listen to your patients in the clinic. We all have that 10%, and we need to remember that we have to do something for them. Because the drug does work, and I would point out that the drug works in lower doses. I mean, the phase 2 studies showed that the minimal dose in the phase 2 study still gave an FEV1 improvement of more than 10% and a sweat chloride drop. And again, that's a very simple measure. Physicians have been doing it for decades, dose reduction.
That's a very good point, and thank you for bringing that up. And I think the key part is, like you said, there are patients who do not feel well from a mental health perspective on this. So as opposed to saying, oh, but most patients do fine, let's continue this, it's to listen to them and then say, what changes can we be made? Do we know 100% it's related? I think it's irrelevant. Like you said, we can dose reduce, and certainly in our clinic, we've done that. Do we know 100% it's related? No, but their symptoms get better, and then they can decide whether or not they want to go back to the full dose. Alternatively, in some of the case series I showed, although in small numbers, people were alternating doses, morning and evening, and again, that did seem to lead to some improvement. So I think the fact of the matter is, patients know themselves. We don't always need a scoring system to tell us.
And I suppose I'd sort of put it out to the CF community. For 20 years, we were brilliant at using antibiotics in ways that they weren't licensed to be used. We twisted things around, we adapted and personalized. But there is a fear with modulation that in some way adjusting dose, or as you say, flipping dose. I mean, if you're monitoring patients carefully, we are clinicians, and we have a therapy that's, the value of it is just, it's transformational. But we have to think, the work needs to be done. The 90% that are treated, we don't have to work on them as much. So we really do need to think about this, and I think your talk, and I think the Canadian data, that 10% figure, that's certainly what we published from our case series as well, about a 10% figure. And I think it's really important, and we shouldn't be frightened of, no one's frightened about reducing frusemide because it costs about €2 if you do, but we're kind of all fearful of reducing a drug that's expensive. That's my sense.
Dr. Plant, you've earned 2 candies. We have another question from the audience.
I'll be really quick. Brooke Moore, Children's Minnesota. Our case series was included in that meta-analysis that our social worker helped conduct. And I just want to do a little plug that we repeated the same in our toddler and preschool age patients using the pediatric symptom or preschool pediatric symptom checklist. And we have a poster 579, but we did not find any difference pre and post modulator in our toddlers and preschoolers that we screened. It's a small study, but just wanted to put that out there for people.
Thank you. I'll be sure to check that. So that was poster 579, she said.
Go ahead.
I just wanted to ask if there was any recognition in some of the limitations of the PHQ-9 or GAD-7, in that it is a questionnaire that a patient would be filling out, often handed to them by a person that they see once a year, where they may or may not feel comfortable, especially in the pediatric population, the 12 and up, may or may not feel comfortable checking any of those boxes, disclosing any of those things. So it's just such a quick snapshot. I'm wondering if that was captured.
It wasn't, but that's a great point, and something actually even in our own clinic we noticed. Initially it was the social worker bringing this questionnaire, going towards the patient, or going with the patient, going over it, and then we realized, again, anecdotally, that if people were doing it on their own, you left the room, we seem to get different results. But no, good point, and that was not captured in any of the data that I've presented.
Oh, thank you.
Can you comment on the other part of the question, which means how good is this questionnaire for younger children?
Oh, yes. So this has not been validated as far as I know in younger children, and maybe the person who just spoke up could correct me, but this was predominantly a questionnaire. There's a slight difference. I don't know if it's the PHQ-8. There's another similar questionnaire in pediatrics, but this is predominantly for adults.
And another question from online. Do we have recommendations on what to do when people are complaining from anxiety or depression and they're treated with ETI? Are there general rules? Are there personal ideas about what to do? Is this dose dependent? Should we decrease the dose? All this stuff?
Yeah, so I'm not aware of any guidance that we have in that situation. Certainly, different case studies I've read have done different things. I think over time it would be great, similar like we do in the liver data, where if your LFTs are this is what's recommended. For now, what we've been doing at our site is stopping the PM dose. That's not based on anything other than some review of the literature. However, as I said, I have seen other reports talking about alternating of the dose. We've even in some patients, if they still felt that potentially with those 2 pills in the morning, none in the evening, still having symptoms, we've gone to 1 tablet once a day. But again, this is not based on any evidence per se.
Hi, I'm not sure that this works, so I'm going to shout. So I know that that some people do this leaving out the evening dose, but these side effects have not really been picked up with ivacaftor before to the same degree. So for me, it does make no sense to do that. So I think we need to have a bit more of a rational approach to this.
Mm-hmm.
Okay, great. Thank you so much,
Thank
Dr.
you.
Corriveau. So next, we'd like to welcome Dr. Rafael Hernandez, who is a pediatric infectious disease physician and assistant professor at the University of Washington. And in addition to his clinical practice, he runs a large laboratory research program focused on understanding how to best treat complex infections in people with cystic fibrosis. Welcome.
Thank you for the invitation to speak today. First, my disclosures. I don't have any financial disclosures related to the data that I'm presenting today, although I should point out that several years ago, I was a study subject in several vaccine trials, so I did receive small payments for those. I will be discussing non-FDA approved vaccine use, but it's supported by the current CDC guidelines. And I have used a few trade names in this presentation, and that's because sometimes for some of the newer vaccines, the generic names or references are somewhat ambiguous. So when I was asked to give this presentation, I went back and looked through the literature to try and identify what clinical data we have for vaccine use, and especially in recent years, related to the new vaccines in cystic fibrosis. And I have to admit that it's rather limited. But so I've tried to apply the data that we have for the general population and information that we have specific to cystic fibrosis to the new recommendations. And I'm going to use the ACIP guidelines from the CDC as a framework for today's discussion. And so first, I'm going to discuss that there is an important role for our CF centers in actually ensuring that our patients are up to date in their vaccinations. And then I'm going to review some of the recent changes in guidelines, focusing on respiratory viruses, pneumococcal vaccines, and then some data related to the importance of ensuring that our patients are vaccinated for human papillomavirus. So first, I wanted to discuss that there is an important role for our CF centers in ensuring that our patients are up to date with their vaccines. So one study that supported this was a quality improvement project that came out of Primary Children's Pediatric CF Center in Salt Lake and I believe some satellite locations. And there, their pharmacy team implemented a pharmacy-driven quality improvement project to try and increase their immunization rates based on a collaborative practice agreement where the pharmacists were able to essentially review and order immunizations for all of their patients. And so they began by initially looking at the rates of vaccination for all vaccines, but especially focused on some of the adolescent age vaccines that are given to in the general population. And the pharmacists, in order to do this, obtained certification to administer immunizations as pharmacists and gained access to all 4 state immunization databases for the areas that are served by their CF center. And so they then reviewed missing vaccines with individuals with CF and their families and offered and administered vaccines when patients were eligible. So let's see. So you can see that there was actually marked improvement in uptake of both the polysaccharide pneumococcal vaccine from 20% to above 90%, for HPV vaccines from 40% to above 90%, and for meningococcal vaccines, conjugate vaccines from in the 20s to 97%. And so I do think that there's an important role for all of us to play in ensuring that our patients are vaccinated. And in addition, it's important to remember that a lot of our CF patients aren't actually seeing their primary care provider on a regular basis. One example of this is a single Center study at UNC, 59% of adults at the adult center did not list either a primary care provider or listed their pulmonologist as their primary care provider. And on review of the records, it was found that there was quite a variable rate of completion or at least documentation of recommended screening per the U.S. Preventive Services Task Force, from low rates for cervical cancer and STIs up to higher rates for smoking cessation. So the first big vaccine change that I'd like to talk about today are the changes in vaccines and passive immunization for respiratory syncytial virus. So until recent years, the only intervention that was available specifically for RSV was, of course, palivizumab, which is a humanized monoclonal antibody that required multiple injections across the season for RSV in infants who were at high risk. But now there's several new interventions for both infants and adults. And so there's passive vaccination strategies that are available in infants, which I'll discuss first, and then several adult vaccines that have been approved. So in infants, the new monoclonal antibody has been approved, which is nirsevimab. It's a human IgG1 kappa neutralizing monoclonal antibody that recognizes the pre-fusion RSV-F protein and prevents viral cell fusion and infection. Importantly, this antibody had a 3 amino acid substitution that was incorporated, and so it significantly increases the half-life of the antibody to 70 days by increasing antibody recycling. And the reason that this is important is now a single dose is sufficient for the entire RSV season. So the MELODY trial was the trial that demonstrated that there was significant efficacy of this passive immunization in preventing both medically attended RSV lower respiratory tract infection, hospitalization for RSV, and very severe medically attended RSV infection with an efficacy of approximately 78%. And this is, like I said, in the general population of healthy term and late preterm infants. So the current recommendations from the ACIP are that 1 dose for infants is appropriate who are less than 8 months entering their first RSV season. And we'll discuss in a moment, there's an alternative strategy for maternal vaccination. But then now there's a new recommendation in the second RSV season for infants who are 8 to 19 months starting the season that's specific to cystic fibrosis, as well as many other infants who have other chronic medical problems. But for CF specifically, individuals who have manifestations of severe lung disease, which includes hospitalization for a pulmonary exacerbation in their first year of life, abnormalities on chest imaging that persist when stable, or have a wait for length that is less than the 10th percentile. Importantly, after the first season of nirsevimab's availability, the CDC estimated that its real-world efficacy was approximately 90% at preventing hospitalization. So this is a great breakthrough. In addition, I said there's a second strategy for preventing RSV disease in infants, which is RSV vaccination during pregnancy. So only a single one of the new RSV vaccines is approved for use during pregnancy and in individuals at 32 weeks to 36 weeks and 6 days. And so this is data from the Matisse study, which is one of the primary studies demonstrating the efficacy of maternal vaccination. And you can see that the rates for severe lower respiratory tract disease due to RSV were significantly reduced with an efficacy that was in the range of 70 to 80%, and the same thing for medically attended RSV. The goal of maternal vaccination is, of course, to vaccinate more than 2 weeks before delivery so that you're getting maternal transfer of antibodies across the placenta to prevent infection. There's a theoretical benefit over using a monoclonal antibody in that it produces a polyclonal response, and so there's maybe lower chance of viral mutational escape. But there was a small signal of possible increased preterm delivery, which is why it was only approved for 32 weeks and later in gestation. In addition, 3 vaccines have been approved for RSV vaccination in adults. 2 of these, and they are all based on pre-fusion RSV-F protein. 2 of these are protein subunit vaccines, and 1 is an mRNA vaccine. And so you can see that, so here the Renoir trial, which was a pre-fusion RSV A and B bivalent vaccine, showed vaccine efficacy approximately 66% at preventing lower respiratory tract disease in older adults. Whereas in the Conquer RSV study, which was the mRNA vaccine, efficacy was approximately 80%. I will say that all of the adult studies for RSV vaccines were essentially running during the lower rates of RSV that were seen during the COVID pandemic, and so the outcomes had lower rates than were initially expected. The ACIP had initially recommended considering RSV vaccination for all older adults based on a physician discussion with the individual patients. But this year clarified their recommendation to suggest, based on the initial data from real-world performance, that all adults age 75 and up should be vaccinated, and that individuals with CF, which qualifies as a chronic lung disease, obviously, all adults 60 and up should be vaccinated. The adjuvanted RSV vaccine has been approved for age 50 to 59, but that's based on just immunogenicity in this population, and there's not enough data on efficacy, and so the ACIP declined to recommend universal vaccination in that age group, and it really needs to be determined on a one-on-one basis. There have also been recent changes in influenza and COVID-19 vaccines that I wanted to mention briefly today. And so first I wanted to mention that there's been a proliferation of types of influenza vaccine that are available, and who those vaccines are actually recommended for has varies based on the type of vaccine. So in the US, influenza vaccination is recommended for all individuals age 6 and up. And then this season's vaccines are all going to be trivalent vaccines. So they're going to contain an H1N1 and H3N2 A viruses and a single influenza B virus. The fourth virus, which was influenza B Yamagata, has been left out because it hasn't been detected in global surveillance in recent years. So the inactivated vaccines that are both egg and cell-based are recommended across essentially all age groups, regardless of age, as long as you're older than 6 months. However, there are new vaccines that are adjuvanted and high-dose inactivated vaccines, and those are stated as being preferred vaccines in individuals who are older than 65 because they show enhanced vaccine responses. New for this year, the ACIP has recommended that those vaccines are also suitable for use in adults 18 to 64 who have had solid organ transplant. And we'll just discuss that data briefly in a moment. But there are also a new recombinant influenza vaccine for adults, and obviously the live attenuated vaccine that's also trivalent for those age 2 to 49 that don't have any contraindications. So one of the challenges with determining who these vaccines are most appropriate for is that in subpopulations like those with CF, and in this instance those with solid organ transplant, the data is really limited to guide efficacy. So the ACIP made the recommendation that these new high-dose or adjuvanted influenza vaccines can be used based in the solid organ transplant population based on small studies. So this is a summary of one of those, their assessments, their grade assessment of data in patients with solid organ transplant for the standard dose versus adjuvanted inactivated influenza vaccine. So for outcomes that were considered most important, like influenza-associated hospitalization, or laboratory confirmed influenza, there really wasn't enough data in these small studies to detect any difference in efficacy. But there was small studies that demonstrated that there was improved immunogenicity and seroconversion rates for influenza A and B, which is why they recommended that they were acceptable for use in these populations. And there wasn't any signal for increased graft rejection. Briefly, for COVID-19 and SARS-CoV-2, here in the US, annual vaccination is recommended for all individuals older than 6 months of age. And the formulation this year is going to include the Omicron JN1 KP2 strain. It generally remains deadlier than flu, although we obviously don't have data from this season. And there have more recently been more pediatric hospitalizations and deaths due to COVID-19 than any other vaccine-preventable diseases in the United States. And so I get the strong sense from talking to people at this meeting and also my colleagues at work that a lot of us have given up on actually trying to push repeated COVID-19 booster vaccines. But I want to say, don't give up. There's still potentially some benefit. Some of the initial data from cystic fibrosis suggested that individuals with CF don't have any increased rates of significant disease, but I would say that there's new data that suggests that there might actually be a signal when you look at very large populations that suggests there might be some additional benefit for individuals with CF. So there was recently published 2 large population-based studies from England and France looking at electronic medical record data and looking at the risk of severe outcomes after COVID-19 in patients who had actually received multiple doses of vaccine, including booster doses. So the analysis in the UK, and they were looking broadly across all kind of chronic diseases. And in the UK, they saw that after the 4th dose, there was a mildly increased risk of death in individuals age 50 and up who had a diagnosis of cystic fibrosis. And in France, after 3 doses of vaccine, there was what looked like an increased risk of hospitalization in individuals who had 3 doses of vaccine and for those who had cystic fibrosis compared to the general population. So I think there's still benefit in ensuring that individuals are vaccinated. And as I said, I worry that sometimes we've given up on ensuring that patients are actually up to date on COVID vaccines. So if you look at the most recent CDC data from the last respiratory season here in the United States, in children 6 months to 17 years, the vaccine coverage for COVID-19 was less than 20% cumulatively through the season. And over the summers, we've actually had an increase in COVID cases. The number of ER visits that are attributable to COVID-19 has actually ranged between 2 to 4%, and this includes pediatric and adult populations, basically across all age groups. So I think that there is still benefit to ensuring that our patients are receiving annual vaccines. There have been changes in pneumococcal vaccine recommendations, which I will say are very complicated based on the multiple vaccines that are available in both children and adults, but I wanted to briefly put in a plug. So traditionally, the childhood vaccine series has been completed with PCV 7 or more recently 13, and now there have been approval of 15 and 20 for use in pediatric patients. And so those are now the recommended vaccines for the normal childhood series. In addition, PCV 21 has been approved for use in adults, but I wanted to point out that the serotype coverage, although PCV 7, 13, 15, and 20 actually kind of progressively added additional serotypes, PCV 21 largely, there's a lot of non-overlap. So the serotypes that are covered in PCV 21 are much more limited and notably excludes serotype 4, which I'll get into a moment, but also includes a number of other serotypes that are not in the conjugate vaccines. And those were included in PCV 21 because now the combined coverage for adult invasive disease is something on the order of 85%. However, as I mentioned, PCV 4 or serotype 4 in PCV 21 is not present, and it is responsible for a significant portion of invasive disease in some subpopulations and regions of the United States. So it's important to keep that in mind depending on your practice population. The recommendations are complex, depend on age, the prior receipt of vaccines, the underlying conditions that you're considering in your patient, and so I would strongly recommend that if you are trying to review which vaccines your patient needs, that you actually use an app that the CDC developed, which is available both on their website and for your smartphones, called the Pneumovax Advisor. It only takes a few minutes to answer a question about your patient's birth date, underlying conditions, and which vaccines they received at which days, and it makes it actually much easier to figure out which vaccines your patient needs as opposed to the tables, trying to review through the tables. But for example, a patient who completed all their childhood vaccines and is age 2 to less than 6 and received at least 1 dose of PCV 20 or PPSV 23 does not need any additional doses of vaccine. So if they recently completed their childhood vaccines after PCV 20 was approved for use in children, then they don't need anything more. If they however, have not received a dose of PCV 20 or PPSV 23, perhaps because the site they were receiving vaccines at used PCV 15, then they do need an additional dose. And similarly, in adults who have never received PCV 13 but have received PPSV 23, they do need 1 dose of additional pneumococcal conjugate vaccine. So those are just 2 examples. Lastly, I want to discuss human papillomavirus. As it's recommended in adults and children. There have not been any recent recommendation changes in human papillomavirus vaccination, but it is highly effective in reducing HPV-associated cervical cancers and other neoplasms. Just as a reminder, it's currently a 9-valent vaccine that is based on virus-like particles that are non-infectious, and the 2 primary serotypes, 16 and 18, are responsible for the majority of neoplasms, but the 9-valent vaccine includes 5 more high-risk types and 2 types associated with anogenital warts. The current recommendations in the United States are that all children age 11 to 12 should get a 2-dose series. You can start at a slightly younger age, and you can perform catch-up vaccination to age 26, but if you start at 15 or later, you're going to need more doses. Age 27 to 45 vaccination is recommended based on shared decision-making, but that's a non-FDA approved indication. And the reason I think that it's important to discuss this today is that in the last several years, there's been data that's come out that suggests that HPV complications may be higher in individuals with people with CF. So there was a prospective cohort study conducted in Lyon, France, where women 18 and up with CF were enrolled and cervical cytology and HPV testing was performed. In general, the carriage rates for high-risk HPV were similar to the general population in France. The study did not include a control group, but they did have general data from other survey studies that they were able to compare to. But there were higher rates of abnormal cytology in both the transplanted patients, which is in dark gray, and then, or in light gray, and then, dark gray, and the non-transplanted patients in lighter gray, compared to the general prevalence in the population, which at age 25 and up in France was reported as being about 5%. In addition, there was data that came out of Calgary. So in one retrospective review with lung transplant patients, 35% of 34 patients reported HPV complications, with 11% of them reporting cervical cancer. No patients who had received HPV vaccinations had reported any complications, and overall the rate of cervical dysplasia was higher in patients who had received transplant. And in addition, in a related study conducted by the same authors, they conducted a survey of persons with CF at CF centers across Canada, and there were high rates of reported HPV complications, including cervical cancer and others. So I think that it's important for us to consider that our role as CF providers in improving HPV vaccine coverage. There are resources that help us to discuss this with our patients and their parents. And so this is one example here from the CDC. And I want to also point out that on that initial slide, as I said, patients are willing to get this vaccine if we're offering it. There are a number of studies that suggest that one of the most important and influential pieces of information in patients deciding whether or not they're going to get vaccination is having a discussion with a doctor that they trust. And so you can see that the HPV vaccination rates in Salt Lake City went from 43 to 90%. So again, we do have a role. So as I said, summary in today, CF centers have a role in improving vaccination rates in persons with CF. There are new vaccines and other immunization strategies available for both adults and infants for RSV, which is very exciting for me as an ID doc. And we discussed the subtle changes that have happened in influenza and COVID-19 vaccinations, and that there are many more pneumococcal vaccines available than there had been in the past, and that there are resources to help you figure out which ones your patients need, and the potentially important role in making sure that all of the patients that we see with CF are vaccinated for HPV. So with that, I thank you for attention, and I'm happy to answer any questions as best I can.
Thank you so much for the excellent talk on this important topic. So we'll start with a question in the app. Can you comment on boosters for pneumonia or pneumococcus and RSV?
So for RSV, we don't have any data really yet for boosters. I would say, that's something that I think is going to come out of the long-term surveillance following up both the real-world efficacy and potentially from some of the clinical trials. So we don't know. And so I think that that's something that's important to disclose to patients when they're actually choosing to get this vaccination. But I think it's also important to emphasize that it's been shown that these vaccines are safe and highly effective at preventing significant RSV disease, and that we'll learn more information about whether or not boosters are going to be required in the future. For pneumococcus, we do have a slightly longer track record of understanding that there are kind of additional doses that are suggested at different time points in life, but there's not any regular schedule for booster vaccination at this point. In the past, there had been a recommendation for patients who were getting polysaccharide vaccines that they would get one dose and then a second dose perhaps 5 years later, but that's not actually necessary if patients are getting the conjugate vaccines, because those induce stronger memory B cell responses. So I think that based on the current recommendations now, which like I said can be confusing, it really is useful to go to the app and figure out based on what your patient has already received, what patients or what vaccines are recommended for them in the future.
Going back to pneumococcal vaccination, I understand it very well in young children. In older adults, maybe over 65, which are not that many in CF patients, but the recommendation...
Hopefully, but
it will change. It will change, okay. But how about the recommendation that is made in younger adults, like 18 to 64?
Yep.
64 still young. And I mean, the morbidity of pneumococcal disease in this population, in CF patients, is quite low. So I wonder what is the basis for this recommendation?
You know, I think sometimes the recommendations that come from the ACIP can be a little bit opaque because it really is a panel of people who sit down and review the data and weigh the pluses and minuses kind of each way. I will say that the recommendations based on the new pneumococcal conjugate vaccines are based on, I think, some of the rationale that previously polysaccharide vaccine had been recommended in these patients, and all the data suggests that, if anything, the conjugated vaccines are better and more protective than the polysaccharide vaccines. But where the recommendation for the polysaccharide vaccine, like the strong data to support that, I will admit, I don't know exactly what the actual foundation for that is.
Opaque is such a good politically correct response. I like that. Can you, somebody asks, would you recommend prioritizing flu or COVID vaccine among people with CF if you have to pick one? And just, I'm going to add my own half question onto that, because I was just brainstorming as you were talking. Could we do it like as a winter package, like respiratory virus package, or we just do both at the same time in clinic?
Currently the recommendations are that they can be both given at the same time in clinic. I think that one of the challenges is that not all clinics actually stock COVID vaccines and flu vaccines because the storage requirements are different, but if they can be given at the same time, if they're available, then I think that's probably the best approach. I don't think we have the data to suggest whether or not one should be prioritized over the other if your patient only is willing to get one of them, because it's very hard to predict how one respiratory season is going to compare to the other.
And there's another question just about vaccine hesitancy. I know we saw a lot of it during the pandemic, and the question was about that some of the vaccine hesitancy for COVID has transferred over to influenza. And so do you have any suggestions in the next 2 minutes or less, please? No, I'm just kidding.
As I try not to roll my eyes. Yes, I think that's an unfortunate circumstance of the current media and kind of environment that we find ourselves in. But I do think that I don't think there's a universal solution. And part of it is actually having the time to discuss with your patients. And it may only be 5 minutes, but trying to incorporate that into the clinic visit to understand what their hesitancy is and understand if additional data is going to be helpful, if they need time to think about it, resources that you can provide. But it has been pretty consistently shown that discussions with providers can actually have an impact. How much that impact has changed over time, I'm not totally certain, but I think that's something that we can actually do, in addition to ensuring that the vaccines are actually available when people want them.
Thank you. Go ahead.
How come RSV has not been approved for under 50 in chronic lung disease?
I think because there's not been specific data associated with that. The trials enrolled older adults, and then the one that's been approved for age 50 to 59 enrolled enough adults to look at immunogenicity, but not enough at efficacy. And there's not actually been trials in younger adults at this point.
It doesn't make sense to me, though. In that.
I would agree with that, but I think this comes back to some of the discussion earlier about off-label use for.
The problem is they have to pay for it.
I know.
Yeah,
that's.
I recommend it for my patients if they can afford it and they want to do it.
I would agree. I think that I think it's something to consider on an individual case-by-case basis. Certainly for patients who have much more advanced lung disease, I think that it's something to think about in having a discussion. But I agree that insurance reimbursement is a challenge when using anything off-label, especially when there's no data that you can use to push back.
Any special consideration for the post-transplant cohort of patients?
These vaccines are recommended in post-transplant settings, but there's the limited data that's available doesn't really allow us to recommend one RSV vaccine over another, but there has been some data to suggest that they're immunogenic and hopefully are going to provide some benefit. But the seroconversion rates, my understanding is that they were not quite as high.
Okay, thank you so much again.
So now we move to our last speaker, who is Professor Damian Donnay from Belfast in Ireland. And Damien is Professor of Respiratory Medicine and is former Director of the ECFS, European Cystic Fibrosis Society Clinical Trial Network, and he will discuss clinical trial updates.
Great. Thank you for the introduction, Pierre Regis, and to Ranjani and Pierre Regis for the very kind invite today. So they've given me a very simple title of clinical trial updates and where to start. So here's just a point to begin with. I apologize if I don't include your favorite study. Don't amp me with that one, so I'll do my best to give you an overview. That's my disclosures. So plan for the next 3 or 4 hours is as follows. So we'll discuss some of the abstracts at this year's conference and just to signpost some really quite interesting data. And then we'll talk, which I think is of real interest to us as working physicians on stopping therapies. These are conversations that we have in the clinic. And some of the data, the emerging data, and some of the studies that are ongoing, and tie that into pulmonary exacerbations. Of course, we have to talk a little bit about CFTR modulators, and then we'll talk maybe a little bit about the clinical trial networks and the importance of them across Europe and across the US and Canada and how we work together. And then some trials that are underway, and then hopefully finish before nightfall on the direction of travel. So you will know that the abstracts are published in JCF, and the section on clinical trials and outcome measures are in the following abstracts of 120 to 169. So just shy of 50 abstracts, not just on clinical trials, but really importantly on outcome measures, which the classic outcome measures that we have used over time or may become slightly more challenging in the future. So this is just a snapshot of some of those trials. The first one there is the vanzacaftor data. This was published, the phase 2 trials were published in 2023, and the data was presented just a few hours ago in this morning's session, and I think it was really interesting data showing as a non-inferiority of the single daily dose of this drug. So it's worth certainly checking that out. You'll see there the Mayflower study, which has been a really important part of certainly our discussions in clinic with the increase in pregnancies that are 2 or 3-fold across our networks. So this is, again, really important data. And the ongoing impact of ETI, and we've heard some of those stories, and really important challenges that we see in clinic. The next series, this is a RECOVER study. This is led by Paul McNally from Dublin and is looking at a series of investigations on children and adults on ETI. And this particular abstract is on abdominal symptoms and gut inflammation. And I think this is really important as we look at non-pulmonary challenges as people with CF get older. And I'll circle back to that at the end of my talk. There's multiple studies on coaching and telemonitoring coming from the pandemic, of course, and there's some really, again, nice data from Stephanie Thie and Marcus Mauld's group. Also in this morning's sessions, we presented the data from the HERO-2. This is lung function and pulmonary exacerbations in individuals, and this is the part of the stopping trials where over that time they didn't, and this was a year's data, they didn't see a change in FEV1 and pulmonary exacerbation rate. So, but I'll circle back to that and talk about some of the other studies, because this is really, really interesting part of clinical trials. And measurements are also clearly important alongside our classics FEV1 and so forth. This is some data on progression, early CF lung disease progression by MBW and chest MRI. Then nasal PD in young children being feasible, and then we'll just finish up just with that study on looking at chest CT scan in children and adults with CF. So that was just a selection, and again, apologies if you're slightly aggrieved that your study wasn't there. You can come speak to me later. So stopping therapies. So you will have seen the data on the Simplify study from published last year by Nicole Mayer-Hamblett and team, and this was in Lancet Respiratory, and this was patients, people with CF on ETI. These were 2 parallel randomized open-label controlled trials, and this was looking at discontinuing hypertonic saline, HS, or Dornier's alpha, which is identified as DA. This was 370 and 477 participants in each trial. The pre-specified non-inferiority margin was minus 3% predicted FEV1. And you can see there the closed blue circle is discontinued hypertonic saline. The orange is the discontinued Dornier's alpha, and the continue arm are the triangles, and there's really no difference. This was a 6-week change in looking at FEV1 as the primary endpoint, and obviously the year-long data that we saw this morning, although this was non-randomized, this was just reporting. It was really important data that, and quite a lot of this we see in clinic, but it's really important that we gain some data so that we can make really informed decisions with our patients. This was a follow-up paper. There has been other follow-up papers in mucociliary clearance and so forth. This was a follow-up paper from the group. And this was framed on the basis of looking at what happens after a clinical trial. So you may be randomized to A or B, but what do you do after the trial is over? So this was to explore the use, again, of Dornier's alpha and hypertonic saline over the 24 weeks of follow-up. Here they used electronic surveys every 4 weeks for 24 weeks. And of course, this is self-reporting. We know about the challenges with that and the array of biases that happens with that. But the data showed, and unsurprisingly, that those randomized to stop Dornier's alpha or hypertonic saline were much more likely to remain off that therapy. So I'll just bring you over to this top graph, and this again is just looking at Dornier's alpha. On the y-axis, these are participants reporting non-use. So this is after the study. So this lower light gray arm, and this were people who initially were to, in the study, were to continue with their Dornier's alpha. After the study, the reporting non-use was quite low. So the people that had taken the drug continued with the drug. The people that who were randomized to discontinue generally discontinued, but you can see the rate is around 50%. So they kind of continued with their same practice, but the people who had stopped it, some returned to the medication, whether that was through personal choice, through discussions and so forth. So it's not just so binary that people stop and start, but maybe at times of pulmonary exacerbation, at times of challenging respiratory symptoms, and I think we need to dig into that a little bit more. And that data then, as we talked very briefly there on the HERO 2, which was a year, but non-randomized. Some of you may be aware of in the UK is the CF STORM study, and that is a randomization to either continue with therapies or to stop their mucoactive therapy. So, and we'll hopefully have some readout of that in the coming year. So, want to move on and within the same arena of looking at pulmonary exacerbations, we know they remain a significant cause of morbidity and reduced quality of life. This is a really nice review. I think I see John in the audience there. I didn't know you were going to be here, but it was a really nice review for people to look at. And they have used these graphs, which are pulled from the annual data report at CFF registry, and this is data from 2022. And you can see in the bottom left graph of the pulmonary exacerbation rate pre and post highly effective modulator therapy. And we know the drop. We've talked about the drop that we see in pulmonary exacerbations, and we see that in the clinic. And then over on the right are people with CF who are ineligible. So you have that maintained higher rate of pulmonary exacerbations. But people, back to the graph on the left, but people still do have pulmonary exacerbations, and that's important to remember. So this is another plug, and I see Chris in the audience. This is just working out very well. This is the Stop 360 platform. And this is a platform for clinical trials to develop the evidence base to define the best clinical practice. And there's been multiple publications and so forth on this, but I wanted to draw your attention to a study that's ongoing, and this is the aminoglycoside study. It's a prospective, multi-center, parallel group, randomized, open-label superiority study. And this is looking at IV beta-lactams and aminoglycoside versus beta-lactams only. And this, again, is quite crucial for how we practice medicine as people with CF get older. There's a lot of cumulative effect of aminoglycosides. We know about their impact in hearing and the renal damage and so forth. And so it's a really important part to get some data to show whether there's any change in using the one arm or the other. Primary efficacy is FEV1. This is currently recruiting in the US, and we will hopefully be extending that to Europe as well. What about steroids in pulmonary exacerbation? This is some data from a secondary analysis of STOP2, and the question at that time are adjunctive systemic corticosteroids associated with improved outcomes in acute CF pulmonary exacerbations. The primary outcomes change ppFEV1, and the results from that showing that corticosteroids were co-prescribed for 168 out of 982 pulmonary exacerbation events, so roughly 17%. With that, there was no change in using steroids. There was no change in FEV1. There was no change in time until next pulmonary exacerbation, and no symptomatic improvement. So a really important analysis of data showing really little benefit with steroids. And this is a paper from Val Waters and team just published in the ERJ looking at prednisone for CF pulmonary exacerbations. And this was a Canadian study, randomized double-blind placebo-controlled trial in people requiring IV antibiotics for pulmonary exacerbations. There was 173 events led to enrollment of participants, and 166 of those were assessed at day 7 of IV antibiotics and divided into those that were responders and non-responders. The non-responders is not recovering your baseline lung function to 90% or over. Were randomized then to prednisolone versus placebo. and just bring you over here today, and this was at day 7, and you can see with the prednisone group on the dark blue circles and the placebo on the squares, there was really no difference in the use of using prednisone when it came to FEV1. Did it make people feel better, at least as recorded by CFQR respiratory domain? There was no difference there. And the CRIS score, no difference. And the time, the classic time to end of IV antibiotics till next exacerbation, there was no real difference. So really important data to help people in the clinic make decisions about how we treat pulmonary exacerbations. So moving to another angle of treatment, and it's always really important to at least mention one paper from the chair.
So now you are eligible for one more candy.
which was clearly the intention all along, I know. So this is expanded French compassionate program for ETI people without the 508 CFTR variant. This is from the French network, and I purposely chose this again, showing the use and benefit of networks to answer really important questions that may go beyond what we would classically see with pharmaceutical-sponsored studies. So that's why there's quite a flavour, as you can see, of investigator-led studies within my talk. So the first compassionate program was launched about 2.5 years ago, and there's been some publications on that. This is the latest publication just on Lancet Respiratory last month. And with 83 people with CF have at least one FDA-approved variant, and unsurprisingly, a really good response, 98% response with a significant increase in FEV1. But importantly, there was 360 with no FDA-approved variant and no previous modulator use, and approximately 50 people with CF responded with, as you can see there, quite a significant FEV1. The importance of this is not just solely relying on in vitro testing to predict clinical response. As you know, for the FDA, they will take in vitro evidence. The European Medicines Agency for the EU will require clinical data, so it's important to collate clinical data and therefore using an international database that assembles all individual level reports and case series are really important, and it's quite a powerful message. So this is moving into the concept of these larger clinical trials and how we plan the road ahead. And this is a paper led by Nicole Mayer-Hamblett, published again in Lancet Respiratory just last year, looking at a roadmap, not just for clinical trials in your own vicinity and indeed in your own country, but trying to look at this from a more global perspective. And why do we need to do that? We see the trials coming through can become quite complicated. Certainly with the new nucleic acid-based therapies, there can be quite a few challenges, and I'll move on to that in the next slide. But with smaller populations that may be eligible for studies, the networks are doing a lot of joint protocol reviews. I think this is really an important part of the advancement of clinical trials with network internal discussions, and then using sponsor communication to help design, not so much design, but give advice to sponsors as to a better way to carry out those clinical trials. I'll give you an example of what that might look like and why we need to do that. Sorry, that may be slightly hard to read, but this is a schematic on the development, for example, of a new therapy in CF, including modulator ineligible population. So there was some data pulled from the US registry at that time. So there was just over 1,000 people, for example, in that aged over 18, we were modulator ineligible, with stable disease with FEV1 over 40%. and less than 50% had previous research experience, and less than 25% had recent trial participant experience. So you can see the challenges where you have a smaller and increasingly smaller population. And if you want then to do trials on NABTs, it could be therapy 1, therapy 2, and then follow-up can be different depending on the compound. So the patient population will become more challenging. And you run that in parallel with symptomatic therapy trials with mucolytics, anti-infectives. You can see, again, the population becomes smaller. Therefore, the importance of networks for cross-communication and finding those appropriate patient populations is really important. Shameless plug coming up. So another really important part of our networks is to use high-performing research sites to try and help answer questions that are investigator-led that may be of less interest to pharmaceutical sponsors. And this was a study that we're just closing out now, looking at COVID antibody responses in CF. And this was using a collaboration between the Canadian network, the US network, and the European network. There was a whole host of challenges of getting this across the line. But we recruited almost 3,000 people with CF for this study, and we'll hopefully have some data next year. So what's happening now, and where are things going? This is a quick look at clinicaltrials.gov last week. 187 studies recruiting in CF trials, not yet recruiting 37, active not recruiting 45, over 1,000 completed, and 100 or so terminated. What's the flavor of those studies when you scan through these? You will know a lot of these. You may be recruiting to this. This is inhaled NAC inhibitors, which have always had a challenging time in CF, but there's an active company at present. The ongoing CFTR modulators, which we know about, there are other companies, and there will be there's studies in the US, and through the HIT-CF, the European cohort, there will be a study looking at some like CFTR amplifiers and so forth. The inhaled ASOs, mRNAs, and gene therapy, and they were discussed at length in the plenary yesterday. There are multiple companies in this arena, all at the one time, and therefore there can be challenges, obviously, with patient cohorts and so forth, which is the importance of networks. But it's not just all about just mRNAs and gene therapy. There's trials on biofilm disruptors, phage therapy, SGL2 inhibitors, and so forth. So just the last couple of slides looking at sort of direction of travel. This was a paper by Katie Heisert, looking at some of the challenges of underrepresented populations, mild lung disease, rare variants, and these are some of the challenges that we will see ahead of us. And the CF community perspectives are crucial in this, and indeed in a lot of grant applications, it's important how you refer to the James Lind Alliance and the 2023 priorities on the right. So we'll not go through these, but these are some of the challenges that are important to address with research studies in the coming years, and this is a publication in Thorax last year. There was also a recent report from the CF Trust in the UK about growing older with CF, and you can see some of the challenges raised there on the complexities of aging, diet, body composition, cancer, and CF, cardiovascular disease, and brain vascular disease, and so forth. And that could be a flavour of how things will, some non-pulmonary challenges that we will see. And finally, the European series on standards of care for people with CF, this is just published, and this is the last paper in the series of 4, and this was planning for a longer life. And it's really pertinent that something like this is published now. It's really worth going through this because there's all the challenges that we are seeing now and in the future will be hopefully ripe for us to understand with some research. So to conclude, we are in a new era of CF. There's a wide range of clinical trials just reported and those still recruiting. Clinical trial networks are an important part of delivering some of those larger studies efficiently and effectively and working together to design new investigator-led studies. Some of the newer studies are really quite complex. And it's important that we maintain our investigator-led studies. So the challenges are different, but out of that arises new questions. Thank you very much.
Thank you for a great talk on this broad topic. Since you've made one or more chairs happy, you'll be shortlisted to do this again next year. So,
my mistake.
So I'll start off with a question. So you and I are aware and have discussed some of the challenges of these multi-country studies. And so do you think that there could be efforts of the different trial networks to put some, I'm going to call it infrastructure, but something in place, sort of like a multi-country platform-ish thing, to then better expedite future studies?
I think we have to do that. We learned through experience and discovered a lot of things and a lot of challenges along the way. We are used to doing investigator-led studies in your own country, but to do that cross-border, you then enter into areas of contracting and insurance policies and so forth, which isn't something that we generally do or are terribly knowledgeable about, and the legal challenges, care and so forth. And we'll see that with some of the studies that may have been arising in the US and coming to Europe. So with all this, we're gathering a lot of new knowledge. We know the challenges that will need infrastructure, because to do these studies is incredibly expensive, and some of the larger pharmaceutical companies have certainly deeper pockets than we would have within a grant network, but there will have to be investment if we wish to do these.
Thank you.
Just, Damien, you showed us a pipeline with many different molecules, and some of them are nucleic acid-based therapy, but some of them are just symptomatic therapy. But at the same time, you showed us data in people with modulators showing that people want to discontinue treatment, and we know that the pool of people without modulator is very small, and these people are most likely to be enrolled in newer therapies that had nucleic acid-based therapies and so on. So do you really think there is room for developing non-CFTR targeted treatment in the current CF population?
I think this is a major challenge, because you have an ever-decreasing population pool, and therefore the attraction may not be for the more of the symptomatic therapies. But I think we are still seeing, even in those people who aren't on modulators, still have symptoms. They may be stopping treatments, but we know that some people are returning to those treatments. One of the bigger challenges, if we then move into a cohort of people who are on modulators, for example, for the symptomatic therapies, it's then the endpoints for those studies is the real challenge, because trying to see a change of 5% or 7% in FEV1 in somebody on a modulator, even though they may have symptoms, is going to be really challenging. So I think the endpoints that we have used we will still use, but we now need to look at other slightly more sensitive radiology, multiple breath washouts and so forth. We've struggled for years with biomarkers. That remains a struggle, so there may be composite endpoints. But in order to get data on all those composite endpoints, you need very large databases in order to dig into that data.
And any data on the willingness of these different populations to participate to clinical trials?
I think there's been a little bit data on the willingness of, for example, of somebody to go into a clinical trial, maybe stopping some therapies. There is some willingness there, but the studies will need to be relatively short, and that in itself can be a challenge. Looking at different populations, for example, with rare mutations ineligible, there are cohorts that are not within networks. So I think it's important networks can potentially expand into areas and countries where there's a higher percentage of people who are ineligible. And we see that, for example, in Southern Europe, where there's less F508del, and into Eastern Europe as well. But then you may have the challenge then of standards of care being slightly different and some reticence with industry to move into places where they're not so assured of a good standard of care.
Okay, so thank you again, Dr. Downey, and to all of our wonderful speakers and to all of you for attending.